All right, so this chapter covers the action of drugs, and we'll kind of go through, or if you've read the chapter, why plants produce so many chemicals um, that we use as drugs, maybe distinguishing among generic brand and chemical names for drugs, um, understanding dose relationships, drug administration. Those are just some of the key ideas that we'll cover in this chapter. So, sources of drugs. Today, most drugs, both legal and illegal, are synthesized in a laboratory, but this wasn't always the case. For most of human history, the drugs came from plants, and many of those plants produced chemicals that have effects on the intestines, muscles, as well as other brain functions. So, when we look at names of drugs, commercially available compounds have several kinds of names, brand and generic, as well as chemical. The chemical name of a compound gives a complete chemical description of the molecule and is derived from the rules of organic chemistry for naming any compound. Generic names are the official names of the drugs and are listed in the United States Pharmacopoeia. Although a generic name refers to a specific chemical, it is usually shorter and simpler than the complete chemical name. Looking at brand names, the brand name of a drug specifies a particular formulation and manufacturer, and the trademark belongs to that manufacturer. A brand name is usually quite simple and as meaningful as the company can make it. For example, the name Concerta was chosen for an ADHD drug to help indicate that it would help patients concentrate and be more alert. When a drug goes generic, the original manufacturer might reduce the price of the brand name product to remain competitive. A competitor may also develop new formulations of the drug. For example, um, the Concerta was originally marketed in 1955 by Novartis under the brand name Ritalin, but after the patent expired, several other companies sold their own generic version of the drug. If we look at the categories of drugs at low or moderate doses, stimulant drugs produce wakefulness and a sense of energy and well being. At larger doses, stimulants can produce a manic state of excitement combined with paranoia and hallucinations. If these drugs are taken over extended periods of time, especially without sleep or proper nutrition, at low doses, depressant drugs appear to depress inhibitory parts of the brain, leading to disinhibition or relaxation and talkativeness that can give way to recklessness. As the dose is increased, other neural functions become depressed, leading to slowed reaction times, uncoordinated movements, and unconscious. Opioids are a group of pain killing drugs that produce a relaxed, dreamlike state. Moderately high doses give to non tolerant individuals, often induce sleep, and pharmacologically, this group is known as the narcotics. And it's important to distinguish them from the downers or depressants. The psychiatric medications include a variety of drugs prescribed by psychiatrists and other physicians to treat symptoms of mental disorders. The antipsychotics, such as Abilify, are also called neuroleptics. They can calm patients who are experiencing psychosis, such as, or as well as lessen unwanted thoughts that often accompany this condition. The antidepressants, such as Zoloft, help some people recover more rapidly from seriously depressed mood states. As with any classification system, some things don't seem to fit into the classes. Nicotine and cannabis are two such drugs. So this slide just breaks down the classification, gives you a little bit more of a description underneath the different drugs. But as with any classification system, like I had said, sometimes the drugs don't fit, right? So nicotine and cannabis were two of them. There's a lot of reasons as to why it's important to identify exactly what drug is represented by a tablet, capsule, or plant substance, which we'll talk about on the next slide. And so there's something called the PDR, which is the Physician's Desk Reference. And this has many years been published with color photographs of many of the legal manufactured pharmaceuticals. Even illicit drugs can sometimes be identified by visual appearance. And often the makers of illicit tablets containing amphetamines, such as MDMA, mark them, but usually in a consistent way so that they can be recognized by the buyers. If a case involving illicit drugs is to be prosecuted in court, the prosecution will usually be expected to present the testimony of a chemist indicating that the drug had been tested and identified using a specific chemical analysis. The effects of a drug do not depend solely on chemical interactions with the body's tissues. With psychoactive drugs, in particular, the influences of expectancy, experience, and setting are also important determinants of the drug's effects. Non-specific effects of a drug are those that derive from the user's unique background and particular perception of the world. Non-specific effects are also sometimes called the placebo. These effects, because some can often be produced by an inactive chemical or placebo that the user believes to be a drug. The effects of a drug that depend on the presence of the chemical at certain concentrations in the target tissue are called specific effects. And with the double blind procedure, this tests for effectiveness of a new drug and must be done doing this double blind research procedure. Neither the experimental participant nor the person evaluating, which is the researcher, um, knows whether a particular individual is receiving the placebo or the experimental drug. So double blind, the researcher and the participant don't know who's getting what drug. When the experiment's over and all the data is collected, then the relevant individuals are informed about uh, uh, which participants comprise the drug conditions. Placebo effects have been shown to be especially important in two major kinds of therapeutic effects, treating pain and treating major depression. It's been known for the past 50 years that at least one-third of psychologically depressed patients that are treated with placebos show improvement. In some published studies, the rates of placebo response have even been higher. Perhaps the strongest demonstration of the specific effects of a drug is obtained when the dose of the drug is varied and the size of the effect changes directly with the drug dose. And so in the next slide, you're going to see a graph that shows the relationship between the dose and the effect. And this is the dose response curve. In some drug response interactions, the effect of the drug is all or none, so that when there is a response, it's maximum. It's also important to note that outcome measures may differentially affected by the drug dose, and some outcome measures have a higher dose thresholds than others. In this figure that you're seeing, it shows a series of dose response curves for three different effects of alcohol. And as the dose increases from the low end, first a few and then more and more of individuals show a slowing of their reaction times. If there's a test for ataxia, which is staggering or the inability to walk straight, one can see that as the alcohol dose reaches the level at which most individuals are showing slowed reaction times, a few are also beginning to show ataxia. As the dose increases further, many people show ataxia and some people become unconscious. They pass out, cannot be aroused. At the highest dose indicated, all of the individuals would be unconscious. When we look at the safety margins, it's uh, important part of the preclinical animal testing that's done on the drugs before they're tried on humans. To determine an effective dose, or ED, it is necessary to define an effect in animals that's meaningful in terms of the desired human use, although this can be difficult. So, for example, testing a new sleeping pill, a hypnotic on several groups of mice, or 20 mice each. Each group will receive a different dose, and an hour later, see how many mice in each group are sleeping. If one assumes at the lowest dose tested only one of the 20 mice was asleep, and at the highest dose all were asleep with other values in between, by drawing a line through these points, one can estimate the dose required to put half of the mice to sleep, which is the ED50, or the effective dose for 50% of the animals. Before a drug is marketed, toxicity is usually measured in at least one animal study by determining how many animals die as a result of the drug. Sticking with the same experiment as previously discussed on the last slide, they check each cage the next day to see how many mice in each group died. And from such a study, one can estimate the LD50, which is the lethal dose for 50% of the mice. The therapeutic index, or the TI, is defined as the LD50 divided by the ED50, and ultimately it's required to estimate the dose that will produce a desired effect in most patients, and the lowest dose producing some unacceptable toxic reaction. The difference between those doses would be called the safety margin. Virtually all of the psychoactive drugs discussed in your text have an LD1 well above the ED95 level. So the practical limitations on whether or not or at what dose a drug is used is the occurrence of side effects. With an increasing doses, there's usually an increase in the number and severity of side effects. The If the number of side effects become too great and the individual begins to suffer from them, the use of the drug will be discontinued or the dose lowered, even though the drug may be very effective in controlling the original symptoms. The potency of a drug is one of the most misunderstood concepts in popular discussions of drug use. Potency refers only to the amount of drug that must be given to obtain a particular response. I'm going to say that again. Potency refers only to the amount of drug that must be given to obtain a particular response. The smaller the amount needed to get a particular effect, the more potent the drug is. So, time-dependent factors here. In the mouse experiment, 1 hour was picked after administering the drug to check for the sleeping effect. Obviously, one would have to learn a bit about the time course of the drug's effect before picking an hour. The time course of a drug's action depends on how many things, including how the drug is administered, how rapidly it's absorbed, and how it's eliminated from the body. The usual way to obtain a prolonged effect is to take an additional dose at some time after the first dose has reached its maximum concentration and started to decline. If doses are taken too close together, the maximum blood levels will increase with each dose and can result in the cumulative effects. Looking at the routes of administration, most psychoactive drugs are taken by one of five routes: oral, intranasal, injection, smoked, or sublingual. Even though oral intake might be the simplest way to take a drug, absorption from the gastro area is the most complicated way to enter the bloodstream. A chemical in the digestive tract must avoid being deactivated by stomach acid, digestive enzymes, and food before it's observed. The drug molecules must next get through the cells lining the wall of the gastral tract and into the blood capillaries. With the oral administration, once it's in the bloodstream, the dangers of entering the route through the oral route are not over. The veins from the gut go first to the liver. If the drug is the type that is metabolized rapidly by the liver, like nicotine, for example, very little may get into the general circulation. Drugs can be snorted through the nose, so the mucous membranes of the nose contain a rich supply of blood vessels that line the nasal cavity. This ensures quick access to the general blood circulation while bypassing the liver, which means that the onset of drug effects is faster than it is for oral administration. Intravenous, or taking it through the IV or direct injection, like you see here, chemicals can be delivered with the hypodermic syringe directly into the bloodstream or deposited in a muscle mass under the upper layers of the skin. With the intravenous IV injection, the drug is put directly into the bloodstream, so the onset of action is much more rapid than with the oral administration or other means of injection. A crucial disadvantage of IV injections is that the vein wall loses some of its strengths and elasticity in the area around the injection site. Another potentially vital concern associated with this route is the danger of introducing infections directly into the bloodstream, either from bacteria picked up on the skin as the needle is being inserted or from the contaminated needles and syringes containing traces of blood. The risk is especially great if syringes and needles are shared among users, and this has been a significant means by which AIDS and other bloodborne diseases have been spread. Subcutaneous and the intramural or intramuscular injections have similar characteristics, except that absorption is more rapid from intramuscular injection. Muscles have a better blood supply than the underlying layers of the skin, and thus there's more area over which absorption can occur. Inhalation or inhaling is the drug delivery system used for smoking nicotine, marijuana, opium, and crack cocaine, and for huffing gasoline, paints, and other inhalants. It is used medically with various anesthetics. Onset of drug effects is quite rapid because the capillary walls are accessible in the lungs, and the drug thus enters the blood quickly. The sublingual administration of a drug is placed under the tongue, and after dissolving, it is absorbed. The area under the tongue has many blood vessels, facilitating absorption and avoiding the liver and first pass metabolism. One downside of the sublingual route is that some drugs don't work when given this way. And the last one, topical application of a drug to the skin is not widely used because most drugs are not absorbed well through the skin. However, for some drugs, this method can provide a slow, steady absorption over many hours. Application to the mucous membranes results in more rapid absorption than through the skin because these membranes are moist and have a rich blood supply. So transporting to the blood, when a drug enters the bloodstream, often its molecules will attach to one of the protein molecules in the blood, albumin being the most common protein involved. And as long as there's a protein drug complex, the drug is inactive and cannot leave the blood. An equilibrium is established when the free unbound drug and the protein bound forms of the drug in the bloodstream. As the unbound drug moves across capillary walls to the sites of action, there's a release of protein bound drug to maintain the proportion of bound to free molecules. Considerable variations exist among drugs in the affinity that the drug molecules have for binding with plasma proteins. The blood-brain barrier keeps certain classes of compounds in the blood and away from the brain. Some drugs act only on cells outside the central nervous system, where others may affect all neurons. One is the makeup of the capillaries in the brain. These are different from other capillaries in the body because they contain no pores. Even small water-soluble molecules cannot leave the capillaries in the brain. Only lipid-soluble substances can pass the lipid capillary wall. About 85% of the capillaries are covered with the glial cells. This is little extracellular space next to the blood vessel walls. With no pores or close contact between capillary walls and the glial cells, almost certainly an active transport system is needed to move chemicals in and out of the brain. The blood-brain barrier is that cerebral trauma can disrupt the barrier and permits agents to enter that normally would be excluded. Chemicals that have an effect on all neurons must do so by influencing some characteristic common to all neurons. One general characteristic of all neurons is the cell membrane. It is this membrane that some drugs seem to act, and by influencing the permeability, alter the electrical characteristics of the neuron. The various types of psychoactive drugs like opioids, stimulants, depressants produce different types of effects primarily because each type interacts in a different way with the various neurotransmitters in the brain. Psychoactive drugs can alter the availability of metabolism, uh, the availability of a neurotransmitter by increasing or decreasing the transmitter chemical's rate of synthesis metabolism. Release from storage vessels or reuptake into the releasing neuron, or the drug might act directly on the receptor either to activate it or prevent the neurotransmitter chemical from activating it. Before a drug can cease to have an effect, one of two things must happen. It may be excreted unchanged from the body, usually in the urine, or it may be chemically changed so that it no longer has the same effect on the body. Although different drugs vary in how they are deactivated, the most common way is for enzymes in the liver to act on the drug molecules to change their chemical structure. This usually has two effects. The metabolite uh, no longer has the same action as the drug molecule, or the metabolite is more likely to be excreted by the kidneys. The most important drug metabolizing enzymes found in the liver belong to a group known as the CYP450 family of enzymes. Although the CYP450 enzymes are always available in the liver, the introduction of drugs can alter their function. Many drugs, including alcohol and barbiturates, have been shown to induce or increase the activity of one or more of these drug metabolizing enzymes. Once the body's cells detect the presence of these foreign molecules, they produce more of the enzyme that breaks down the molecule in an effort to normalize the cell's chemistry. Enzymes induction has important potential not only for tolerance to that particular drug, but also for interactions with other drugs that might be broken down by the same enzyme. The enzyme activity typically returns to normal sometime after the inducing drug is no longer being taken. Not all of the metabolites of drugs are inactive. Both diazepam or Valium and marijuana have active metabolites that produce similar effects to those of the original parent drug and prolong the effect considerably. These so-called prodrugs are being developed that are inactive in the original form and become active only after they are altered by the liver enzymes. There are at least three mechanisms by which a reduced drug response can come about: drug disposition, tolerance, and behavioral tolerance, and the pharmacodynamic tolerance. Sometimes the use of a drug increases a drug's rate of metabolism or excretion. This is referred to as a drug disposition tolerance. Another possible mechanism for increased elimination has to do with the pH, the acidity of the urine. When the use of a drug interferes with normal behavior functions, individuals may learn to adapt to the altered state of the nervous system and therefore compensate somewhat for the impairment. A person who regularly drives a car after drinking alcohol will never be as good as a driver as he or she would be sober, but with experience, the impairment may be reduced. In this type of tolerance, called behavioral tolerance, the drug may continue to have the same the same biochemical effect, but with a reduced effect on behavior. All right, and as we wrap up here with the pharmacodynamics tolerance, this is a tolerance that's caused by altered nervous system sensitivity. It leads not only to a reduced effectiveness of the drug, but also to withdrawal reactions. So for most of human history, drugs came from plants, right? But now we have all these chemical names or, things derived from plant substances. And the sales of legal pharmaceuticals in the US exceeds 500 billion every year. Uh, so that about wraps up this PowerPoint presentation today. I hope this helped to better understand your actions of drugs as they move throughout the body. Thank you.